All right, I would like to introduce myself. My name is Deanna Makota, and I am your host for today, which simply means that I have the pleasure of introducing our presenters as well as moderating our Q&A segment, which we're going to save for the conclusion of our presentations. So stick around for that. Many of you had submitted really thoughtful questions, which our presenters have received. They viewed, and I think a lot of questions are going to be answered throughout the presentation, but if there is something that you would like to hear or need a little bit more detail on, we will make sure to get to as many questions as we possibly can. All right, so let me formally welcome everyone to Finding Relief Advances in Hip and Knee Replacement, which again is brought to you by the Cleveland Clinic. I would like to introduce both of our specialists today. They work very closely together, so I'm going to introduce them in tandem. First, I'll start with Dr. Nicholas Scarcella, who is an orthopedic surgeon here at the Cleveland Clinic. Dr. Scarcella specializes in hip and knee surgery, specifically around the knee. He performs both partial and total knee replacements, as well as complex and revision arthroplasty. Similarly, he performs both anterior-based hip replacement surgery and posterior, as well as complex and revision hip arthroplasty. And he also uses robotic-assisted techniques for both hip and knee surgery. And then next we have Pawell Sampolowski, who is a physician assistant here at the Cleveland Clinic, working alongside Dr. Scarcella. Paul obtained his master's degree from Baldwin-Wallace University, and upon graduating PA school, began working in orthopedic surgery with a specialty in adult reconstruction, and transitioned to a pure surgical role with a major emphasis on adult reconstruction. This eventually led to his current position here at Cleveland Clinic, with and growing an adult reconstruction practice with Dr. Scarcella. So thank you both for being here. Very impressive bios. We are excited to hear everything that you have to offer. And I'm going to go ahead and kick it over to you, Dr. Scarcella.
All right. Thank you so much. I appreciate it. Well, welcome everyone. This is a nice little, thing that the Cleveland Clinic does to help provide information for, a lot of common questions and things that regard total hip and total knee replacement, big surgeries that, are very common, but also can cause a big recovery in your life in a time frame. And people have a lot of questions. So hopefully we can answer some of those. So I'll start it off. Basically, I'll be talking about new advances in hip replacement, kind of going over the basics of hip replacement, kind of what qualifies you for, what they're like today, and a little bit of the post-op recovery for it as well. So again, I'm Dr. Scarcella. I completed my residency training here at the Cleveland Clinic. So this is where I did train for orthopedic surgery. I did it from 2017 to 2022. And then I went over to Duke University for a fellowship, basically just in adult reconstruction. So doing nothing but hip and knee surgery and hip and knee revision surgery, where I kind of wanted to fine tune some things and learn some new stuff that was outside the Cleveland Clinic. And then I was fortunate enough to be hired back at the Cleveland Clinic in 2023. And currently my practice, I operate at Medina Hospital on the south side, and then also at main campus too, where I do more of my complex surgeries down there as well. So starting off with kind of the basics of the hip. I know a lot of this stuff might be, you guys already know, or, a little bit of review, but, the hip starts with the ball. So the femoral head, which is kind of over here, as I can use this drawing tool. So that's your femoral head. It articulates with the socket, like a ball and socket joint, which is the acetabulum. And these two provide, a range of motion and a very flexible joint that allows people to walk, run, jump, do a lot of things. The thing that makes hip joints and all joints work very well is the articular cartilage. This is basically the lubricating surface of the body and the weight-bearing surface of the body that allows for frictionless motion between your hip joint, your knee joint, and all the joints, and allows you to have no pain, no kind of stiffness and things like that. But the problem is, once in a while, as people get older from wear and tear through life or injuries they sustain or special conditions, this hip joint becomes arthritic. And what happens is the smooth surface and the frictionless surface that you had with your articular cartilage goes away, and you get this roughened, uneven surface that provides pain to your hip, loss of motion and stiffness, and just inability to do activities that you once liked to do. Some of the common things that people will complain of when they start to get hip arthritis early on is pain in the groin. So when people classically think of hip pain, they'll sometimes think of buttocks pain, but hip pain is groin pain. So basically pain deep in your groin crease is where classically hip arthritis will present. Sometimes you can get buttocks pain, but it usually coincides with the groin pain as well. the pain will usually worsen with activities. So, if you're active on a treadmill, doing long distance walking or jogging, usually that groin pain will act up, and that's usually indicative of the inflammatory event that's associated with hip arthritis. And another common one is getting in and out of a car. And the reason why this one's kind of specific is you can imagine when you get that uneven surface, I'll go back a few slides, when you go to move this hip over here, you can see it has all this uneven bone spurs and things on top of the head. When you do that extreme kind of flexion in your hip to get your leg out of the car, you get a lot of pain from that. And a lot of people will complain, listen, every time I go to sidestep out of the car, I get this deep groin pain, which is very common. When you come in, one of the common things that, we learn in medical school and training through orthopedic surgery is physical exams to find specific conditions. When we're diagnosing hip arthritis, it's pretty specific on how we kind of find it. The most common reproducible thing we'll get is we'll put people in this position where we'll flex their hip up, we'll internally rotate or have their knee point towards their opposite shoulder. And usually this will cause a deep groin pain in someone with arthritis. And again, it's because as we go back to these slides, this uneven surface starts to pinch against the other bones when you put your hip in that position, and you get pain, and it refers to your nerves, and it helps us diagnose it. Some questions that people kind of have when, am I ready for a hip replacement? I'll ask them a few questions, and there's 4 questions. One is, how bad does the pain bother you? Does it prevent you from doing the activities that you previously once enjoyed? Does it prevent you from doing things with your family, whether you have grandchildren or keeping up with the family on vacation? Are you limited when, you have pain in the groin, you can't walk far if you're going on a vacation or touring around somewhere, and you just can't do it anymore because of this pain? Does the pain wake you up at night? It's an inflammatory condition because you have inflammation in the joints. So classically, people will wake up at multiple hours of the night with groin pain, and it's because this is where a lot of the inflammation happens. If you ever had a lung infection or any kind of other things, a lot of times at night is when you get a lot of the symptoms. It's because inflammation tends to rev up at night. And then do you find yourself modifying your activities, that you previously once did? So let's say, you used to walk a long time around the block and go hiking, and now you're using walking sticks, or now you're using a cane, or now you're just not walking anymore just because the pain bothers you so much. So you're kind of modifying what you're doing mostly because of the pain. The last thing we'll do is we'll get x-rays. So we got the exam findings, we got the history of the things you're telling us, and then we'll get an x-ray to kind of see what's going on in your hip joint. So over here on this side, this is a normal hip joint. You can see right up on this area right here, you can see the bone, the space between the femoral head, the circle-shaped bone, and the socket. There's a space right up in here. That space is your cartilage. Cartilage doesn't show up on an x-ray, so the space between those bones gives us an idea of how well your hip's doing. This is a normal hip. It's got a lot of cartilage. It's not touching each other. Versus look at the other hip on this side over here. Over there, you can see that this hip joint has minimal space between the two bones right up here, and it's got kind of bone spurs down here, this kind of white kind of faded chunks over there. And you can see also up through here, you can see all this kind of white reaction in the bone. That's called sclerotic bone. And what that is that's bone that unfortunately had its cartilage withered away, and your bone on bone, and your bone reacts by getting very hard and white. And we see that on x-ray. So that's kind of a couple signs we'll talk to you about when we see you in the clinic when we're diagnosing you with hip arthritis. So, we always, as surgeons, our first thing is to treat non-operatively. You should never see a surgeon and they should jump right to surgery. That's kind of not our goal, because obviously we want to do the simplest treatment first to see if we can get you by, because chances are I can take an x-ray of about every 60 and 70-year-old in the country, and about 40% of them probably have arthritis, but they don't even know it because they don't have pain. So we don't treat an x-ray. We don't go to surgery just because you have arthritis. We do things that sometimes get you by. And a lot of you have probably maybe even already done some of these things. We start with NSAIDs, Motrin, Aleve, over-the-counter anti-inflammatory medication. Celebrex, Mobix are prescriptions we'll do because they're a little bit stronger and sometimes have a safer profile in your stomach. The only issues with these sometimes is they have side effects. So we don't like to put people on them for a very long term, because there are side effects with your kidneys and stomach, and they can cause you to have heartburn, and sometimes there's a rare instance of kidney disease that can happen from them. The second step we'll do when people fail kind of activity modification and NSAID medication is going to a steroid injection inside the joint. For hip joints, they're a little bit more tougher than a knee joint. We'll talk about that when we get to the knee section. But for hip joints, unfortunately, it's a very deep joint. You can't just do it from the office. We have to do it under ultrasound or x-ray guidance to make sure it gets in the hip joint. And it's sometimes tough to get in there. Unfortunately, with hip injections, they just don't work as well as knee injections do. Knee injections are easy to get in. People tend to have pretty predictable relief. With hip injections, sometimes it's a little bit less. Some people don't get the full 3 to 4 months we expect, or sometimes they only get a week or so. It just happens to be how the dice kind of roll with it. But we do try it for people who want to continue to pursue non-operative treatment, or they have big things going on in their life and they can't undergo surgery. And we try to provide them with another means to have pain relief so they can keep their function up. The only caveat is with the injection is every time you get an injection, you cannot have a surgical procedure from 3 months afterwards. And sometimes people don't know that, and they'll get the injection, and let's say they only get a couple of weeks of pain relief. And like, doc, I think I need the surgery. Well, unfortunately, we have to wait 3 months after that injection because there's an increased risk of infection because steroids dull your immune response, and you need your immune response to protect you from an infection during surgery. So I'll always tell people that about an injection. Like, listen, I'm hoping it works for you. I hope it gives you a lot of pain relief. But sometimes if it only works for a month, we're stuck for another couple months till we can do anything because we don't want to give you a risk of infection. Another thing we'll always do is, encourage exercise and losing weight. And the reason why is because, unfortunately, losing even a few pounds decreases a lot of force going through your hip joint and a lot of force going through your knee joint. So even if you only lose 5 to 10 pounds, you'd be surprised on how much that adds up, because that could be almost 100 pounds of force getting reduced through your hip and your knee. It's almost 6 times when you do sitting and squatting activities. So even a little bit of weight helps reduce the amount of force going through that. Less force on a arthritic knee or a knee starting to go through degeneration can help it last a little bit longer. Now, kind of the final thing we'll talk about is surgical treatment options for people with, hip arthritis. Again, this is our kind of last effort for people who've failed conservative treatment. And this is, obviously what we see people the most for, because they tend to usually come to our clinic when they've already kind of exhausted the non-operative treatments. So total hip replacement, what it consists of is a few parts. One is a metal cup that you can see up here. Basically what we do is we use reamers and we recreate a circular socket in your bone. And then we fit a metal cup that has a bone on-growth surface into the pelvis. And what happens over a course of 6 weeks is your body actually grows into that metal component and becomes permanent and a part of you. And we have that technology nowadays that they've become even better at growing in. The other component we put in is this femoral stem that you can kind of see here. Basically, we use reamers and broaches to open up your canal of your femur. We take the head off that you previously saw in the x-ray, and we basically size your femoral canal over here to the appropriate implant size, and then we put the metal component inside and your bone grows into it. Once in a while, we do use cemented components. It's because of elderly people who don't have good bone stock and we can't rely on their bone to grow in. So we will sometimes use cemented femoral components. And then the other part of the total hip replacement is the liner that goes in between. You can see here this plastic liner right here and this head. Nowadays, we use ceramic heads and a plastic liner or a polyethylene liner. They've shown to have good wear rates. What wear rates mean is how long will they last inside your body as you're walking around and moving around. They're thinking nowadays that hip replacements can last 20 to 25 years with the new kind of polyethylene liners and ceramic heads that we use nowadays. Before that wasn't the case. It was about 10, 15 years. People had trouble getting hip replacements when they were 50 or 60. Now we can do them younger because we know total hip replacements can last longer and prevent a person from undergoing a revision for a longer period of time. So after I see you and we talk about surgery, the thing I will do while you're kind of getting worked up by various teams to make sure you're ready for surgery is I'll do some surgical planning. I'll use a templating software to predict what size components I will use in your total hip. Basically, I do this so I know going in what will fit you appropriately, and I have all the information for me on what would be normal. And this just helps me be accurate so I'm in the surgery, and if something doesn't feel right, I'll refer to the template, and I kind of know which direction I'm going, and it makes it a lot more accurate. And majority of the time, what I'm templating is what I'm putting in because we have nice kind of software that helps us kind of plan this. So what are the goals of someone who undergoes a total hip replacement? And, you probably heard a lot of different things on different people getting back to certain activities. The first one is pain relief. You've had long, deep-seating groin pain that's lasted a lot of time. Prevents you from sleeping, prevents you from doing household function. That's the main goal, is pain relief, to get rid of it. And luckily, hip replacement is an excellent surgery. It's actually one of the best surgeries we have in medicine, with over 95% of people being happy with their pain relief. And the other things are the things that we like to really get people back, and that's improvement in function, back to quality of life, and being happy, getting back to the activities that you previously enjoyed, whether that's golfing, hiking long distances, walking long distances, bowling, gardening. I'll never say that I can tell people to get back to serious exercise, but they do. But it's getting you back to the things you once enjoyed that you gave up for because you had hip arthritis. Again, what I kind of said before, it's one of the best operations in medicine. We're lucky to have this as a part of our field, and other surgical specialties always kind of laugh, but 95% of patients, you will not find this in another surgery except for cataract surgery, maybe, are satisfied and get complete pain relief from the hip pain they once had. So that's kind of a excellent thing, and that's kind of one of the reasons I chose to go into this, is because I have the fortunate ability to do a surgery that can give people a lot of benefit. It's also one of the most common procedures performed. And again, we're going on 20-25 years of survivorship with the new plastic liners and the new ceramic heads. So they're lasting a long period of time, and more people don't have to wait and suffer for a longer time to get older to get a total hip replacement. Another thing is a low complication rate, 1 to 3% of the various complications that we'll talk to you about in office. That's relatively low for surgical procedures. If you think of the huge scope of kind of what surgery is, whether it's general surgery, vascular surgery, heart surgery, things like that, that's a relatively low complication for surgery. And we're fortunate in orthopedics to be able to have that. And then good question, is there room for improvement? Always. We're always kind of looking for what is going to give people the best outcome and lead to the lowest kind of surgical complications and risk associated with it. And we'll kind of talk about a few things, whether it's advances in different approaches that we're using, different pain regimens to kind of make your early post-operative period easy, and then also how we make implants last longer so people don't have to undergo a revision surgery again in their life. So preoperatively, the big thing is we're trying to control pain after surgery, because it is a big surgery. It's a surgery that we make a decent size incision to get the components in correctly and aligned right. And we have to go through skin, soft tissue, do bone prep work that can be painful for the body. So what do we do for that? We will do prehab kind of physical therapy sometimes before to make sure your muscles are strong and ready for recovery. And then we'll also get you medications for surgery. So one of the kind of standard medications that we'll use prior to surgery is oxycodone. That's a narcotic pain medication. And obviously, with the recent, history of narcotics and kind of the problems with the country, you got to understand this isn't just getting pain medication because you're getting pain. You're having a major surgery where pieces of your bone we have to take away. And oxycodone is a medication that can provide you pain relief for the first week or two. Obviously, we're not doing it past that, and we're making sure that we're managing your pain responsibly and appropriately. But it is an important pain medication early on to make sure that you're functioning and still able to do the things to keep you, taking care of yourself in the early period. The other one is different NSAID medications. I use Mobic, but we sometimes use Celebrex. These are NSAID prescription medications that have a safer kind of kidney and stomach profile, and it provides an anti-inflammatory effect, because after surgery, you can imagine your tissues are inflamed because you just had surgery, and this kind of helps reduce the pain and the inflammation. And then also anesthesia, we'll use steroids in the kind of surgical perioperative period, and this just helps kind of reduce some swelling and some pain as well. And also at the time of surgery, we'll do injection into the various tissues in your muscles, and then into your capsule, and then into the areas that we split with a knife. And this just helps kind of dull the nerves and gets rid of the pain that the nerves are transmitting to the brain, and kind of helps people recover early on because it gives them about 24 to 48 hours of pain relief in those areas. And then also we do when we do anesthesia, we do a spinal anesthesia. There's two different types of anesthesias for orthopedic surgery. There's spinal anesthesia and general anesthesia. General anesthesia is the classic one that you probably think of. That's having a tube down your throat, putting you completely to sleep, and a ventilator kind of uses its machine to allow you to breathe and to control your vitals and things like that. Spinal's different. A spinal is just like, if for women, if you've ever been pregnant, it's the same thing. We give you an injection around your spine that kind of numbs all the nerves from the waist down. It's safe, it's got minimal risk and side effects, and it lasts for about 2 to 3 hours. So it makes you numb, and then we lightly put you to sleep, but enough that you breathe on your own. You're completely numb. You're having the surgery. You're not awake. You're not aware of what's going on. You're not hearing what we're doing. You're not seeing anything. You're not feeling any pain. You are still completely asleep. You're just not deep enough asleep like a general anesthesia where they have to control your breathing and monitor your vitals. The benefit of a spinal is there's decreased blood loss, decreased risk of infection, decreased risk of blood clots, easier length of stay. Most people get home within a day. If they have a general, they're at risk for staying 2 to 3 days just because you have high dose anesthesia medications that make it tough sometimes. And then again, it's a team effort. It's between us and kind of anesthesiology to team up to make sure your pain is managed appropriately, to allow you to do physical therapy in the hospital and to be successful. This is kind of the thing I was alluding to. So back in the day, you know, this was kind of our big problem is we'd have these kind of wear and these polys, and this is what we'd see after 10 to 15 years. We've had new techniques in how companies manufacture polys that now allow them to last 20 to 25 years. And what changed is basically how they processed them. Before, they used to get oxidized inside the body and oxidized inside the packaging. So when they would go in the body, there'd be a lot of wear because they'd oxidize and the metal would kind of scrape up the plastic. And over time, you'd get that problem that I circled there. Nowadays, because we do different kind of irradiation, different types of processing, different types of formations, different type of additives in the poly, we've managed to create polys across all companies, which are the same, that last longer, 20 to 25 years. And we're thinking the ones that we're putting in now may even last longer. So the thing that we talk about is changes in kind of hip approaches to see if we can affect people's ability to recover. Traditional hip approaches from, over 40 years was the lateral and the posterior approach. And we'll kind of talk about them a little bit and talk about the new ones that we've been doing now. So traditional approach, this one over here that I'm circling, this is the lateral approach. Basically, we would go split your glute medius tendon, one of your big abductor butt muscles, and split your vastus lateralis, one of your quad muscles, and we'd open up the hip joint that way, and we'd put a hip in. It was a good approach. It was very stable, had minimal dislocations. The problem with this is, you can imagine, you had a tough time recovering because we actually split your muscle and its tendon and repaired it, and people would usually have a limp or even pain afterwards because all those muscles would scar it and not work as effectively as they did before. The other one we would do is the posterior approach, and that's what this one's looking at. When we go in the posterior approach, to get a look at this deep hip, we actually have to split your gluteus maximus muscle. That's your big muscle in your buttocks. And then we get a view of these smaller muscles, and then those get split to get inside your hip joint in here. So there's a lot of muscle splitting, and it's our way of getting in the hip joint from the back to put in a total hip replacement. The problem with that is it had some instability problems early on. A lot of it had to do with hip designs, but it's because a lot of the times when people dislocate, it's from the posterior portion, and those muscles would protect it, and they were gone after these surgeries. I'd still do a posterior approach. It's a good approach for, revision surgeries or people with anatomic problems or more difficult total hips. But I'll talk about another approach I do as well. It still has its role today. And with the newer implant designs, that dislocation risk is a lot lower. It used to be upwards of 2-3%. Now it's around 1% and even getting lower than that. And we'll kind of talk about the other ones. So here's the newer ones that people are doing now. So there's two, and they're anterior approaches. There's two different types. The classic one that most people do, and the most people you'll hear about, is a direct anterior approach. And basically this goes between two muscles. It goes between your sartorius muscle, which is your muscle on the inside of your thigh that's circled here, and your TFL muscle over here. And what it does is it goes in between the muscle intervals, so you're not splitting any muscle. And when you go in between them, you can see this is your hip joint capsule down here. And we're able to get in and put a total hip replacement through this without splitting any muscle. The benefit of this is you get less pain, less soreness and scarring of your muscle, and a less dislocation risk because we're doing it from the front. Its dislocation risk is around 0.5%. Posterior, it's around 1%. So you can see it kind of cut it in half. Another anterior approach that we do, and this is the one that I do, is called an anterior-based muscle sparing approach. The difference between this and the direct anterior approach is just which side of the TFL muscle, which I'll circle right here, you go in on. The one I just showed you, the direct anterior, uses this one. The ABMS uses this one. So this is kind of the incision. It goes through this area right here in between the muscles and kind of spreads those muscles apart. The benefit is similar to a direct anterior. It's got lower pain, easier function, low dislocation risk. It actually has a lower dislocation risk than the direct anterior approach. The reason I do this approach is it's what I trained in at Duke, and also it has the ability to have a large revision component. So if something were to happen during surgery, it's easy to expand the incision and fix it. With the direct anterior, it's not so much. You actually have to make a second incision sometimes in a different part of the femur to be able to fix it if there were a fracture or something like this. With my approach, if that were to happen, doesn't happen often. It's a very rare problem, but if it does, I can keep the same incision, fix everything, and give you the same total hip that you had. So that was the one reason I trained in it, and I brought it back to the Cleveland Clinic. Here's what the incision looks like for an ABMS. The size of it can vary. Can be about this size, can be a little longer sometimes. Just depends on, how large the patient is, how deformed the hip is, how bad the arthritis is. But basically, I make the incision about that size. And if I have to make it bigger, I do it because it's what safely puts in the implants. And you can see this is the ABMS approach. It kind of wiggles between these muscles. It doesn't split them. It goes between the intervals. It spreads them apart, and it puts the total hip right between those muscles. So for me, this is my kind of cutoff for what I do for total hips. I do both approaches, both posterior and anterior. For my anterior total hips or my ABMS, I require people to have a BMI of 35 or less. And the reason why is with anterior approaches, you get closer to the groin and closer to kind of the inguinal region that you can sometimes have your abdomen kind of fold over the incision sometimes. And if it does, it can cause a wound healing problem. So I do require people to have a BMI of less than 35 for this approach. And that's pretty standard for all anterior approaches. The direct anterior is actually even more close to your groin. Mine's farther away, but I keep this just because I want to you to have the lowest kind of risk for any kind of wound healing problems or infection. For all my other ones, my BMI cutoff's 40. So for a posterior approach, it's a little bigger. And the reason why is it's farther away from the groin. It's easier to kind of see things and manipulate tissue to be able to successfully put a total hip in. So I do posterior approaches for some people who, either are taller or bigger or have bigger deformity. For diabetics, my goal is to have an A1C of around 7.4, so less than 7.5. And the reason why that is because if you have a hemoglobin A1C of greater than 7.5, our research has shown that your risk for infection triples. So I don't want to do a surgery that can put you at a high risk and give you an infection. So I'll work with your primary care doc to get your A1C under control for the period, just to make sure you're at the best chance of having a successful hip. Then I also get preoperative labs, and this just checks kind of your baseline, making sure that, everything is good and there's no kind of conditions lying around the background. And then I also send you to the medicine team before surgery. And this just makes sure that they're looking for any background things that you didn't know. They get EKGs, labs, things like that, and take a look at everything to make sure you're doing okay. I also do robotic. Basically, this is a CT-based platform that maps your anatomy and allows your surgery to go as accurate as possible. Basically, there's a robot arm that you can see down here. And what I do is I ream with the robot arm in the exact position I want to place your cup up here, and allows for complete accurate placement of the cup. Why we do it robotically sometimes is robotic surgery, at least from the posterior approach. So when I'm doing posterior approach, allows for your dislocation risk to be almost close to 0.5%. So that almost equals an anterior approach. So that's why we do robotic surgery from the posterior. Anteriors, I don't do it. And the reason why is I just don't find the benefit for it. People do well with anterior approaches. They have low dislocation risk anyways. Adding a CT scan and maybe another 5 minutes to the surgery doesn't change the outcome. But for a posterior approach, it can. So I will do robotic surgery for that, or if someone requests it. And then again, it's a team effort to get you ready for surgery. It's seeing the medicine team, seeing the physical therapy team, seeing our team, seeing the anesthesia team. All these people kind of come together to make sure you're optimized for surgery to have the best outcome. And that's how we do it at the Cleveland Clinic. Other places can get you in faster. Other places can, not optimize things up to the thing. I do it by the book and by how I was trained here and at Duke. I make sure that everything is optimized so you have a successful outcome and have the lowest risk of complications. The big thing that, the risk that we worry about the most is infection. So I'm sure whether you've known somebody or have heard of it, there is a risk of any of all surgeries have an infection. For a total hip, it's around 0.5%, or 5 out of every 1,000 people. How do we reduce the risk? We optimize you beforehand, make sure your medical conditions are controlled, you know, the diabetic, quit smoking, all that kind of stuff, making sure that all your conditions are optimized to make sure your infection risk is low. We give you antibiotics IV for 24 hours. That helps reduce the risk of infection. And then we also have new dressings that we use that kind of seal in your incision from the outside world and actually have an antimicrobial surface inside the dressing that helps reduce infections. And we actually showed this at a study we presented last month that it actually reduces the risk of infection and soft tissue problems around 1/3. So it's kind of a new advance we've had in the last 5 to 10 years. This is just a table that I use. This is a table I use for my ABMS or anterior approaches. So I actually put you on your side similar to all the other total hip approaches. And this is kind of the view I look at when I'm doing the surgery. Basically, I have a couple of retractors up top. It's kind of tough because it's a little bit farther away. I'm looking at the surgery from the top, putting in the components there. And this is just us with your kind of hip dislocated, giving us a view of the femur. The benefit of having an anterior approach or an ABMS approach is the restrictions are less compared to a posterior approach. People have posterior approaches are not allowed to bend over and do those things or cross their legs. With an anterior approach, those kind of go out the window just because we're not disrupting those posterior structures. So your risk of having a posterior dislocation is very, very low in this approach. So we don't need to have those restrictions. How does surgery look like? So anterior approach patients, you know, post-operative day 1 or in the early post-operative period have been shown in studies to have reduced pain in the early post-operative period. At 1 year, the surgery, whether it's posterior or anterior, do the same. That has been shown in the literature. Early on, around, you know, the 1 week to 1 month, anterior approach patients or ABMS patients have less pain compared to posterior. We see that in the studies. So that means more function, less pain medication, things like that. Nowadays, late to stay, most people are staying in the hospital about 1 night and then going home the next day. We also do outpatient surgery where we send people home the same day of surgery. And then we just, you know, do some background checks, make sure you qualify, make sure you have help at home, make sure, you know, you're relatively healthy, that we don't have to manage any conditions, that any, you know, side effects or problems occur. And we work with you to make sure that that can happen safely. So we do that about 20 to 30% of people. Most people go home with home health care. So that means physical therapy will visit your house for the first 2 weeks after surgery. They'll work with you on doing daily life things, some exercise, and make sure you're recovering appropriately at home. And then after that, we'll give you an outpatient PT script if needed. A lot of my hip patients don't need it. Knees are different. Most knees will go to outpatient PT. A lot of hip patients don't need it just because once you kind of replace their hip, they feel a lot better. They're moving well, and hips just don't get as stiff as knees do. Just to talk about my practice a little bit on how I, you know, do various hip surgery. About 60% of my surgeries are anterior, 40% are posterior. The reason why I still do posterior is I still think it has its role and it's important. I would caution anyone for someone who is extremely biased in one approach, because, you know, there are instances where different approaches actually benefit people and make them have a more successful outcome and less risk. So being able to do it from the, you know, anterior side and the posterior side of the hip has its benefits. So basically, when I talk to you in the office, I give you my opinion on what I feel like is the best approach for you and allow you to be successful. It's not a one approach for all comers. You know, the new kind of thing is anterior approach is kind of the new hot thing that everyone's doing, and it's got earlier, you know, pain relief, but it's not for everyone. Some people require a posterior approach for it to go successful. I've seen a lot of anterior surgeries that have been forced in people that shouldn't have had them, and they ended up with really bad problems. I'm a hip revision surgeon, so I also see those people and have to fix them. And when they go wrong, they can go bad. So I make sure I select the approach that's the most appropriate. I'm not just doing one for everyone. I'm doing the one that's going to make it safe, you have the best outcome, and get you back to what you really, truly enjoy to do. And then I also do robotic. I do in about 20% of cases. Again, it's usually only for my posterior approaches. Again, I don't see the need for it in an anterior approach because it's already a stable approach. The robot's meant to get the cup as accurately placed as possible and to reduce dislocation risk. Again, anterior already has a reduced dislocation risk, and me adding it to the surgery is not going to really change that percentage anymore. So I do it mostly with just my posterior. They'll talk about, you know, if you want questions or contact my secretary or me, this is my phone number, but, you know, I'm sure they will provide it to you at the end. So that's kind of it that I have it with with the total hip portion. So I'm going to pass it over to my partner in crime, Pawell, to talk to you about the knee stuff.
Thank you so much, Dr. Scarcella.
All right. Hi, guys. I'm Pawell Sampolowski. Like Dr. Scarcella said, I work alongside him in the Medina team for joint replacement surgery. So I'll be taking over the knee replacement portion of the presentation. So a couple little introductory things. You know, there's various types of replacements and different things we've been doing in knee surgery as of late. So, you know, total knee replacements, partial knees, outpatient replacements are the new kind of up and coming thing where some patients can actually go home same day as opposed to staying the night or 2 nights in the hospital. That multimodal pain management, like Dr. Scarcella mentioned, you know, the spinal anesthesia and the intraoperative injection, things like that. That's what that means. And then robots, as he touched on, to place the implants in their appropriate spot. So, you know, the problems are basically life expectancy is increasing in our country, and younger patients are experiencing arthritis. So as we get older, we expect to be active. You know, no one wants to kind of just sit around and do nothing when we get old. We all want to, you know, be a part of our pickleball team. We want to go golfing on the weekends, enjoy time with family, things like that. So as we get more active, we want to actually function appropriately. So the average amount of total knee replacements per year is about 600,000, as opposed to that 450 that Dr. Scarcella mentioned for total hips. So what is arthritis? So some of this may be a little bit redundant and repeat from Dr. Scarcella's, just because, you know, both are arthritis, both are kind of wear and tear, and different joints are affected. So osteoarthritis is that degeneration or that wear and tear. You know, we get older, our joints kind of rub and that cartilage gets thinner and thinner, and we become a little bit more bone on bone. The other types of arthritis involved are rheumatoid arthritis. This is where the body's immune system is actually actively attacking the joints, and this commonly affects hands, knees, and things like that. So the third one there being traumatic arthritis. You know, if you were in a major accident and it affected your joints, you have a higher likelihood of arthritis and deformity kind of in the future. So what is arthritis? That cartilage that we spoke about, the cushioning or that buffer system between the bones. It's smooth, low friction surface, so it glides a little bit smoother. And then the arthritis component it's now replaced by this rough, high friction, bone on bone kind of grinding or crackling. If you notice, you move your knee up and down and you notice some crunching in your knee, that's arthritis and that bone on bone kind of moving around. So this picture here depicts more so what a normal situation looks like. So on the left-hand side, you'll see a door hinge, and that is indicative of the way the knee functions. So the knee kind of bends out and back, but it also has a little bit of rotation as well. So it kind of functions as a door hinge, but a little bit more movement with that rotation. And this picture depicts a little bit more of what an arthritic knee would look like. So on the left-hand side, the door hinge is a little bit more rusty. It's kind of worn out, broken down. It's obviously going to squeak and shake and rattle a little bit more than that nice brand new hinge that was, you know, recently greased and brand new. So that right-hand side, if you notice all of these jagged pieces of bone all around, and that kind of cartilage has worn off and has gotten bald, that's that bone on bone arthritis. So knee replacement surgery, basically in a nutshell, is we remove the arthritis and we resurface it with the artificial joint, kind of like that hip replacement where these components of the cup, the poly, and the stem. The knee is also a similar concept in resurfacing the joint. So we like to mimic that nice, smooth, low friction surface as you would have with a normal knee with all of that cartilage in the form of the knee replacement. And knee replacements can also fix specific deformities. So on that right-hand side, you'll see two different deformities, one being the valgus knee or knock knee, as we sometimes refer it, and then varus knee, or kind of the bow-legged kind of deformity. So knock knee is basically when the outside compartment is worn off and more arthritic, so your knees kind of tend to get closer together, and that bow-legged is the inner portion of your knee is actually the one majorly affected, and that is actually the compartment that is primarily affected with arthritis. So as mentioned before, there's two types. So there's a total knee replacement and a partial knee replacement. Both have their ups and downs. It's more of a, am I a candidate for one versus the other? So, when do you need surgery? Kind of like Dr. Scarcella mentioned, getting back to that quality of life, doing what you want to do safely, kind of pain-free, and enjoying yourself in your later years. So when medical treatments like those anti-inflammatories, the pain medication, injections, and things like that, if they have failed, that's usually the time where we pursue surgery in order to keep up your active lifestyle. So the available treatments, like I just mentioned, so modification of activities. So basically the common thing is if it hurts, don't move it. But that's not always the case. Sometimes we replace, if you're an active runner and you can no longer run your 5Ks, your half marathons, things like that, people tend to go towards swimming, bike riding, things that aren't so impactful on their joints. So they still stay active. They just find new avenues to do it. The analgesic pain medication, those are usually the Tylenols, the topical creams that we find over the counter. Those anti-inflammatories or those non-steroidal medications are ibuprofen, Aleve, and the prescription ones that we mentioned of Mobic and Celebrex as well. So physical therapy is great for strengthening the muscles around the knee as a kind of a support system and stability. And it helps us train our bodies to move more effectively and a little bit more pain-free. Unloader braces. So we usually utilize these when, one of your compartments is a little bit more collapsed than the other. And we can actually fix the deformity and offload that arthritic portion with this kind of big bulky brace that goes over the knee prior to possible surgery. So the injections, as mentioned before, so cortisone injections are that steroid that go into that joint space, helps reduce pain, inflammation, swelling, make things a little bit more comfortable. There's also gel injections or hyaluronic acid. Those are more of a kind of like it says a lubricating shot. So, the Tin Man in the oil can, his joints are squeaking. He oils himself up and now he's moving a little bit more fluid. That's similar to what a gel injection would provide. So it helps the bones glide smoother, less of that crunching, crackling, and an inflammatory response, hopefully providing with some pain relief as well. And then finally, we've exhausted all of these avenues that you see up top. The surgery is our last option. So like I just mentioned, all surgeries, or all treatments fail. You go to surgery with either that partial or that total knee replacement. And this is, just piggybacking off of what Dr. Scarcella mentioned, you want to get back to an active lifestyle. You can see grandma on the left-hand side kind of sitting in the chair and her whole family's going on a nice bike ride. Chances are she's not able to do so anymore. And this might affect some people mentally as well. I'm not happy because I can't do these things. So that's when we try to get you back to what you enjoy. So, you used to be able to walk around, and go to the kitchen, stand for long periods of time, cooking dinner with the family, or just getting up and using the restroom. But now we're a little bit more in pain and I can't even walk 20 feet without having to sit down. So that quality of life is a little bit more diminished as well. So getting dressed, using the toilet, eating, and things like that, all things we kind of take for granted. Yeah, sure, we do them on a day-to-day basis, but we don't really realize how physical some things can be. So that knee replacement, that hip replacement is meant to get you back to doing these things more pain-free, without as much assistance as you would need to, and a little bit more safely, as far as like being a fall risk or things like that. So another kind of avenue that some people may look into is, can I get a scope procedure for delaying a replacement? Can you just quote, clean out my knee, clean up the arthritis, and kind of make me feel a little bit better? This is not really indicated anymore. Just because, people with arthritis tend to have some degree of maybe a meniscal tear as well. So if we go in there, clean up some fraying cartilage and get the meniscus, sometimes it can actually make your arthritis progress a little bit faster than you would have expected it to, because you no longer have that buffer system of that meniscus between the two bones. So resurfacing, this is kind of the picture of what a total knee versus a partial knee would look like. That left-hand side being the total knee, all of the surfaces are nice and replaced. And then on the right-hand side, you can notice that there's only that white portion that you see, and that is actually the inside portion of the knee. And everything else is more natural and kind of just basically you without any arthritis. So these are the compartments that I mentioned a little bit earlier. So the inner compartment, or the medial compartment, is about 80% of people have it in this compartment. That lateral or outside portion is about 15%. And then underneath your kneecap, or that patellofemoral compartment, is about 5%. So it's, your knee is one joint, but it has various different parts and components to it. So we really need to take a look at the entirety of the knee. Making sure we do what's right for you. Every surgery, every patient is individualized. You can't just do like a blanket surgery for everyone. We really look at everyone kind of on an individual basis. So that partial knee replacement, this is that medial or inner compartment on that picture there. So if you have disease, deformity in just one compartment, and everything else seems to be kind of squeaky clean and no arthritis, you're basically a candidate for a partial knee. So sometimes you may grab even a CT scan or an MRI to depict, is there any arthritis in the other compartments? If not, then you would more so be a candidate for that partial knee. So why use a partial versus a total? It's more natural feeling. 2 out of those 3 compartments are still natural, and they're still you. And that one compartment has been resurfaced. Since we're only tackling one compartment, it yields to a smaller incision and less blood loss, just because there's less bony cuts that we have to make. And then it's slightly easier in the early part of recovery, just because we're not involving the entirety of the knee. We're just kind of minimizing it to that one compartment. Unis or partial knee replacements and total knee replacements, pretty equal on the pain relief, just because you have arthritis, we took care of the problem, and that was just kind of time to get back to normal. So this is that medial partial knee. On the left-hand side, you'll see that bow-legged deformity there. And then on the right-hand side, you'll see that it has now been resurfaced, and the knee is more kind of straight up and down, more balanced, so to speak. So the patellofemoral compartment, this is that 5% that we mentioned. And that second picture there specifically, we call that the sunrise or the merchant view. You can actually see the spacing between the bones there on the outer portion is now kind of worn off. So right about there, it's been worn off, and that's bone on bone. And now it's just time to resurface this one compartment. So on the right-hand side, you'll notice that big white circle here. That is actually on the femur portion. So your kneecap runs in this groove called the trochlea. So that is the portion that we resurface. And then over on the far right there, that is also that merchant view that shows after the replacement's been done, that whiter portion being the replacement of the trochlea. And then on top there's the kneecap that we put a little plastic button on the back of. So your bone is not just gliding on metal. It is that polyethylene button gliding in that metal trochlea now. So, we mentioned why do a uni, but, why shouldn't we do a uni? So total knee replacements have an increased survival at the 10-year mark of longevity of the prosthesis. So that 95% versus 92%. The risk of progression over the arthritis. So we mentioned we leave 2 of the compartments alone and they're naturally you. So if you were to get arthritis, say in your lateral or patellofemoral compartment, this would basically lead to a total knee replacement, which would cause a second operation or a revision procedure. Okay, so why do 2 surgeries when you can just do the one? That's kind of the thought process there. And then specifically, you cannot do partial knees in folks who have had ACL or PCL injuries. So the former athlete, ACL rupture, never really got it fixed, and now his knee's kind of a little bit more unstable. Inflammatory arthritis, so that's that rheumatoid that we mentioned before. If you have a really bad deformity, sometimes we can't bring you back to that neutral, and it'll put more pressure on the other compartments. And then, like we mentioned, if you have multiple compartment arthritis, so I have arthritis under my kneecap and on the inside portion of my knee, I can't do a partial just because there's more than one compartment involved. So total knee replacement candidates. So this is that late stage arthritis, that bone on bone. You've failed all other treatments. I've gone through therapy. I've done all of the medications, the injections, and nothing is really seeming to help. And now it's limiting my active daily life. Sometimes it's as simple as I want to walk my daughter down the aisle and I can't walk 20 feet. So we want to actually bring people with just the small little things that make life what it is. We want you to enjoy that. And then that rheumatoid arthritis that we couldn't do that partial in, you would need a total knee replacement. So surgery time, it's about an hour and a half or so. It feels a lot longer for the patient just because of anesthesia, waking up, going to sleep, things like that. But the actual procedure time from the moment we make incision to about, closure is usually about that hour and a half. You get out of bed the same day. So you're up and walking with physical therapy, especially when you have that spinal anesthesia. It kind of gets you going a little bit sooner. Hospitalization, we mentioned that you spend the night, usually 1 day in the hospital, and there's that new focus of that outpatient surgery where you have surgery in the morning, you work with physical therapy, and as long as everything's looking great medically and from a physical therapy standpoint, we can send you home in that afternoon. So most of the time people are discharged directly home. For some reason, if you need greater amount of assistance, if it was a larger procedure or if it was like a revision, things like that, you may be sent to a rehab or skilled nursing facility, but primarily people are usually discharged home. And recovery is usually about 6 to 12 weeks for the majority of it. That's when most of that stiffness, swelling, and soreness kind of works its way out primarily in the initial stages. And people actually get improvement up to 1 year after surgery. But that 6 to 12 week mark is usually the ballpark there. So your choices in knee replacement. So there's cemented knees versus bony ingrowth. So Dr. Scarcella mentioned that acetabulum or that cup socket portion relies around bony ingrowth on the metal. That also is an option in the total knee replacement. And then outpatient versus inpatient surgery, going home same day versus staying a couple nights. So these are the differences here. Cemented total knees, has been the gold standard. It's 40 years of success. Basically, we use a cement that holds the knee components into the bone. And these with the new advances in that polyethylene, these can last, 20 to 25 years, sometimes more with that brand new technology. On the right-hand side there, you'll see the press fit or cementless knees. This strictly relies on bony ingrowth into the components. So those folks who have kind of really brittle bone, or if they have kidney disease or osteoporosis, things like that, their bone stock or their bony quality is not as great for this approach, and we would utilize more of a cemented total knee. The cementless knees are usually younger folks with arthritis that still have that good bone stock, are healthy, and we do not want you to fail at any portion of your recovery. So if that ingrowth leads to early loosening, if that bone does not grow, so 6 months to a year of that early loosening, if your bone doesn't grow in, it's not going to hold, and it's not going to last a very long time. And the cementless knees, since it does rely on a bony interface for it to grow into, that is why we use kind of the Mako or that robotic procedure. Very accurate cuts, good interface, and yielding a more successful bony ingrowth situation. So you'll notice the two pictures on the top left and the right. The top left is that cementless knee. Basically looks like looks pretty similar to the other photo, but the main difference on the right hand side is the undersurface of the tibia, that metal tray that you see. It has that kind of gritty metal coating that your bone actually grows into over time. It's a similar coating that's on the back of that acetabulum, as we mentioned before. So, outpatient replacement surgery that same day surgery where, get my new knee in the morning, go home in the afternoon. That's what people usually want, is to go home and sleep in their own bed. So who qualifies for this? Very healthy patients with minimal comorbidities, and those who have a little bit more help at home. If you live alone and have to do everything, it might be a little bit difficult for you to go home same day and just take care of yourself after a major surgery. But if you're healthy, if you're up and moving, if you're safe to go home, we can go ahead and do that. And about 30% of total knees can actually go home same day. So pre-op versus post-op, as mentioned before with Dr. Scarcella, all of the preoperative appointments, medical clearances, we have you talk to anesthesia, all of these different things to get you optimized for surgery, making everything as safe as possible. Education, when we meet with anyone in the office, we talk about all of the perioperative things. So what to expect prior to surgery, what to expect during, and what to expect after, and making sure that everyone has an understanding of what they're kind of walking into. And then immediately pre-op. So as you're kind of in the pre-op area waiting for your surgery to take place, hydration, getting that Tylenol, Celebrex, possibly that Decadron or that cortisone injection. And then, like Dr. Scarcella mentioned, this reduces that tissue inflammation and post-operative pain for the initial period of time. So recovery after surgery, that multimodal analgesia that we mentioned before. So that spinal versus that general sedation, spinal being similar to that epidural that the women who have had children may be familiar with. And then general sedation is usually what you, or general anesthesia, sorry, is what you would see kind of on all the Grey's Anatomy and things like that, the tube down the throat with that ventilator working for you. So that saphenous block that you see there on the screen, that adductor canal, the anesthesia will administer this to help post-operative pain for the first couple days after surgery. And then the liposomal bupivacaine is a intraoperative injection that either myself or Dr. Scarcella will put in for additional pain control in the first couple days after surgery. And that post-operative, we mentioned you're up and walking the same day. Getting up and walking is very, very important to prevent blood clots and pneumonia. And we also do something called incentive spirometry. It's a funky little device that you kind of blow into to keep your lungs open so that they don't have a tendency to collapse in the early portion after surgery. So, discussing the robot, people think we're just going to push a button, the robot's going to do all of the work for us, and that's not the case. Like Dr. Scarcella mentioned, we utilize that CT scan to print a basically 3D model of each individual knee. No knee is the same, so we want to specifically make your surgery as successful as possible. So this provides us with a space safe for surgeons to operate with that robotic arm. The robot communicates with what's going on in the surgery for those accurate, precise cuts. So that precision means less tissue disturbance. We don't have to move as many things out of the way in order to visualize. So it's a little bit less painful after surgery due to that tissue disturbance difference. And these are far more accurate than non-robotic knees and are better for that press fit, that bony interface, like mentioned before, with that software being very, very accurate. So these are two types of robots that are commonly seen. On that left-hand side is the Stryker Mako. This is what we utilize at Medina and main campus here. And then you'll notice that that green portion that you see kind of here and here, that is actually the implant and how it's going to sit on your bone, and specifically making it balance and making it as best of a knee as you possibly can get. And on the right-hand side is the Rosa. Basically, the difference is two different companies, both very accurate, utilizing software in order to make a balanced knee and in order to provide as much success as possible. So the results, you maintain your independence. You're able to get back out there with friends and family. You're kind of back to normal, playing pickleball, golfing, things like that. Everyone's different passions are important. It's what makes you happy. It's what makes life worth living. So we want to get you back to that independence and that happiness. So, here's that golf. The guys out there on an early morning tea time, resuming lifestyle. All of the new technology and things make the implants last a little bit longer, but we can't, shave strokes off your golf game just yet. But it gets you out there on the green and enjoying your time. So our practice, like Dr. Scarcella mentioned, manual versus robotic knees, 60% now are robotic. Cemented versus cementless, it's a 50-50 split. So that bone stock is important. Your overall health in general is important. So we make the judgment call based off of kind of what we see before surgery and what we see during. Sometimes you plan on doing a cementless knee, and once you get in there, there's a little bit more of a softer bone than you had anticipated. So we end up with a cemented knee because it's going to optimize your recovery, and it's going to be better for you in the long run. And that outpatient versus inpatient, those 20% of patients getting out there kind of the same day. All right, so that's the general total knee talk there. Some things may have been a little bit kind of redundant from what Dr. Scarcella mentioned, but arthritis is similar throughout our body, whether it's shoulders, knees, hips, things like that. So hopefully that was a nice comprehensive review for everybody.
Thank you, Powell. That was such a great presentation and wonderful information. We certainly appreciate your time with us. And now is the moment I'm sure that many of you have been waiting for, our live Q&A. Many of you submitted questions upon registration and also flowing in today, and we are fortunate that we have the opportunity to answer some of these questions. So with that being said, I'm just going to get started here. Is a knee replacement possible if you have osteoporosis?
Yes. So osteoporosis basically just means your bones, as you grow older, get a little bit more brittle, and especially with like postmenopausal women, they're even softer, but definitely is possible. We would just utilize more of that cemented approach versus that cementless, because we can't really trust the bony stock that's there. So we would just go ahead and do a cemented total knee.
Okay, so on the topic of cement, if the gold standard is cement, why do cementless if I'm a younger active person and I want to have the best? Why would you choose cement versus not cement?
Yeah, that's a good question. So obviously cementless, they've had designs, 20 years ago that didn't work as well, and the newer ones have been proven to work well. The reason why cementless in younger people we try to do is because you have bony ingrowth into that component, kind of like how total hips are, but total knees, we have that ability to use that technology to make it work. If your bone actually grows into that implant, the loosening ability of that knee over a long run, so if you're 50, 20, 30 years out, is a lot lower than cement. If you have a cemented knee, it will loosen over time. It's because you're relying on that kind of grouty material to connect the implant to the bone. But if the bone actually grows into the implant, it's not going to loosen in the long run. So that's why for a younger person, we will try to do a cementless one and try to do it robotically, because we want the cuts to be perfect, to match the components. But again, like kind of Paul said, we rely on the cuts to be exact, and we rely on your bone stock to be good for it. If we deem it not perfect for it and not right for it, we will do a cemented component, because that's what's right for you and what will succeed. But cementless knees, the prediction is that they're going to be able to last longer.
Excellent. Okay. Here's another question. If I have stairs in my house, will I be able to get up and down the stairs after a knee or a hip replacement?
Yes. So you'll be able to get up and down the stairs. And one thing we actually ask people is, prior to surgery, how many steps to get into your house in the first place. We want you to be able to navigate your home. We don't want you to be unsafe at home. And actually in physical therapy, before you leave the hospital, you actually do walk up and down like 3 or 4 steps with therapy. And they kind of show you how to do it safely and effectively, so that when you do go home, you're able to climb your staircase to go to your second floor.
Okay, that's a relief. Okay, next question is, how long are steroid injections an answer to knee pain?
Yeah, good question. So it's kind of dependent on a few things. One is we want to see at least 2.5 to 3 months of minimal relief from a steroid injection. If you're getting less than that, you're kind of having law of diminishing returns, because each time we do it, it'll usually last less and less. So the first time people get it can last 6 months, 4 months, 3 months. And it kind of depends on that. The other factor, too, is kind of what's going on in your life. A total knee replacement is technically a 3 to 4 month recovery to get you back to doing big activities. If you got a wedding coming up, you want to go on vacation, you got kind of those things. We're not going to tell you because, you had a steroid injection that only lasted around 2 months that, listen, we're not going to repeat it. You need a total knee. It's just not right for your life at that time. So we kind of make judgment calls and kind of have a discussion with you based on kind of the expectation. Like, listen, maybe we can give you an injection before vacation or your daughter's wedding or son's wedding, things like that. And be like, listen, it might only last a month and a half, but it'll get you through this kind of social time in your life that you can't obviously undergo a total knee replacement. So it's a split between how they're working and what's going on in your life. Obviously, we're not going to be repeating injections every week, because that's just going to lead to problems. But, we kind of share the decision making with you to make it work.
Okay. That's good to know. There's a couple of questions on this around this same topic. If I've had an MRI of the hip or any tests done outside of Cleveland Clinic, do you have to redo them once you come to Cleveland Clinic, or can you use those previous tests and MRIs for the surgery?
So, I mean, yeah, yes and no on whether you have to repeat them. Sometimes you can get the images and we can upload them with our software, but if all we can get is the printout of what the results show and we can actually visualize it or identify anything on an actual image, sometimes we would have to repeat it, just because sometimes, you may have gotten an MRI 4 months ago. you know, things happen, and sometimes they can happen a little bit more acutely. So getting a repeat MRI can sometimes be beneficial for whether it's planning or whether it's treatment options for you specifically. It's kind of a 50-50 kind of yes and no answer. Yeah.
If you need it, you'll do it to
basically, yeah,
have better care. Okay. I have a lot of pain in a knee replacement from a few years ago. Is there anything that can be done for that?
Yeah, tough question, but a good question. So obviously, you know, knees, about 10% of them, people don't find the full satisfaction of them, or they have pain afterwards. The tough part about it is a lot of things that can cause the pain, and I can go down a list now with you. But basically, it depends on what's causing you the pain. Is it the component itself? Is it a soft tissue structure around it that's being irritated, or a muscle that's being overused because of, you know, the difference in your gait, or how the knee's working overall, or maybe some tissues getting impinged? It could be a component that's loose or worn out, depends on when it happened. Infection's always a possibility. There's a list of kind of things that can cause a knee to be painful after a total knee. And not all of them require revision surgery or something like that. Sometimes it's as simple as different physical therapy exercises, or, you know, medications, or, you know, changing some kind of things that can sometimes get people's pain to go away. But my job, it's a tough one. You know, when I do knee revision surgery, is to find an identifiable cause and find a solution to fix it. I'll never do a knee revision surgery for someone who's painful and I can't tell them why they're painful, because a lot of the times I'll go in there, do it, and then you'll just still be painful. So I need to know what's causing it. And, you know, it's a pretty comprehensive list. It's kind of the tougher things we deal with at our specialty are painful total joints. And it's our job to kind of figure out what's causing it. Right.
So safe to say, make an appointment. And get it taken a look at. And okay. Here's a frequent question too. I am a diabetic and have had reactions to steroids. Is that common, and can anything be done to eliminate that problem?
Yeah, so I mean, like if the reaction to steroid is kind of that that blood sugar spiking afterwards, there is different types of injections that we may try with the gel injections specifically for that knee. Sometimes reducing the dose of the steroid in the actual injection. You know, we're not going to blast you with an entire dose of cortisone, but if we, you know, cut it in half even to provide you with that relief, but not put you into this kind of diabetic blood sugar spike, we may do that as well. And just from an endocrine and a primary care standpoint, just making sure your sugars are well controlled, not all over the place, whether you need different, you know, alterations in therapy, whether it's metformin, insulin, things like that. We'll have you see your medical doctor to get that under control. But from our standpoint, either kind of reducing that dose of cortisone or shifting it over to that gel injection where you won't get a blood sugar spike as a different kind of mode of relief.
Okay. What if I'm unable to take NSAIDs or Tylenol? Is there other pain relief medications that I can take?
Yeah, it's a tough one. Puts us in a little bit of a tough spot sometimes. There are, you know, once in a while, it depends on what I identify as the cause of the pain. If it's arthritis, that's tough. Sometimes if you can't take NSAIDs and Tylenol is the only thing and it's not giving you a cut, sometimes we got to move to the injectables to kind of give your knee some pain relief, just because obviously whether it's kidney related issues or stomach issues or heart issues and you can't be on NSAIDs, we can't use them. So, you know, once in a while when it's a soft tissue structure that's irritated by arthritis, or we don't think it's arthritis, we'll sometimes do a light steroid orally to reduce the inflammation. But the problem is it's only a temporary kind of fix, because we can only give it to you for like 5 days, because steroids inherently have side effects after around a week if you give them to them. So yeah, sometimes we just march up the ladder. It's not, you know, a serious escalation. It's just getting you to injection therapy and preventing you from getting any of those systemic side effects from NSAIDs.
Okay. And I think we have time for one more question. If I wait for a hip replacement, am I doing more damage to my hip or to other parts of the body?
Yeah, it's a good question. So Not necessarily. So like I kind of said in the hip thing, you know, a lot of people, if I take a x-ray of people 70 years old, I guarantee 50% of them have some form of arthritis or degeneration in their hip, and they don't feel it and they don't know about it. They only know about it when they get an inflammatory event and they come in and the x-ray shows arthritis, and they sometimes get in the cyclic problem of having arthritis. If you have arthritis and you have pain, waiting isn't going to change the outcome of the surgery or the surgery you're going to get. There's a caveat to that. Obviously, if you wait, you know, a number of years and your hip gets more narrow and you grow more and more bone spurs, you can lose motion in your hip joints, similar to your knee. And while we can replace the hip joint, get rid of the surfaces, I can't stretch out the tissues and the contractures that you can get from that cause the hip to be stiff. So sometimes it can affect your range of motion after the surgery. It's tough for us to give a lot of motion back if it's already been restricted. Knees we can, hips we can too, but it gets tougher sometimes. But overall, you know, it's very rare that waiting 1 to 2 to 3 years changes the surgery we're going to do for you. It's going to be the same.
Interesting. That's a good question and a great answer. Well, with that being said, we've reached our time limit. So I would like to thank all of you so much for joining us. Thank you to Dr. Scarcella and Pawell Sampolowski. If you would like to make an appointment with either of our physicians, we've been posting a make an appointment little flyout coming from the left of the screen. And we thank you for your time. If you want to go back and review this event, please know that a link will be sent out in the next day or so. You're welcome to share that link with a loved one or a friend. Also, like I said, if you're in need of an appointment, follow the links that we've provided. And again, thank you very much to our presenters and to all of the wonderful viewers. And please watch for an email with the link to the recording. Thank you so much.